Welcome, everyone. Thank you so much for coming. It is my honor and privilege to introduce this year's Dr. Meredith E. Drench Lecture. Before doing so, it's important that I tell you a bit about the person that we thank for this important annual lecture at Sargent College. The late Meredith E. Drench, PhD, physical therapy, established this lectureship, Sargent College's first endowed lecture series, to share and to propagate her passion and belief in the compassionate rehabilitation of the whole person. Her work extended well beyond the fields of physical rehabilitation and psychosocial behavioral sciences. Her efforts represented the very best of patient-centered care and interprofessional practice, even before patient-centered outcomes held such an important focus in healthcare. Dr. Drench was a remarkable force in healthcare. In her 1998 book, Red Ribbons Are Not Enough, Health Caregivers' Stories About AIDS, she tackled some of the most challenging and sensitive issues involving HIV/AIDS, presenting a comprehensive view of this monumental health crisis during a period when our national response was still emerging. It's a remarkable piece of work, well ahead of its time in many ways. So please sneak a moment, just a moment or two during the next 45 minutes to reflect on and appreciate Dr. Drench's vision for this lecture, to appreciate how this event captures and memorializes her highest ambitions for Sargent. One more thing before I introduce our speaker, I want to thank especially our Sargent College Speaker Selection Committee members, Professors Linda Bandini, Jessica Kramer, Lee Marenko, and Christine Strand, as well as Professor Kara Stepp, who've contributed so much of their time and effort to making sure that this evening is informative and influential and is personally and professionally inspiring to us all. Now I'm extraordinarily pleased to introduce this year's Drench lecturer, Alyson J. McGregor, MD. Dr. McGregor's work came to our attention through multiple paths. In retrospect, it just had to be. She's a 2003 Boston University alumna of our School of Medicine, so she's a homegrown choice. Her 2015 TED Talk, Why Medicine Often Has Dangerous Side Effects for Women, has been viewed nearly 1.5 million times, so she's a safe choice. She's a role model who can inspire our Sargent College community. We at Sargent continuously seek to identify and address our world's most difficult and persistent health challenges. And Alyson provides a remarkable example of how we can contribute. She's an inspiring choice. She's a somewhat surprising model of what patient-centered medicine really is. Recognition that patient-centeredness begins long before the patient shows up in the exam room, well before they complete their intake questionnaire, and even before they become patients at all. Patient-centeredness is essential to our entire process, from the establishment of best practices and standard methods, to our research habits, to our conscious acknowledgement and wariness of our implicit biases, our tacit, untested assumptions, and surprisingly unquestioned beliefs. So she's a thought-provoking choice. And I will admit that we were intrigued by the possibility of meeting the person with the intellectual courage and self-confidence to entitle her most recent scientific manuscript, seemingly derived from the Gian Lorenzo Bernini sculpture of the same name, Man with Finger Injury. So that's a bonus. She's an artistic choice. Please don't look that manuscript up. Not before dinner. Dr. McGregor is an associate professor of emergency medicine at Brown University, as well as co-founder and director of the Division of Sex and Gender in Emergency Medicine, as well as the co-founder and vice chair for the Sex and Gender Women's Health Collaborative. Finally, I hope you'll stick around afterward for a reception in the Setterberg Lounge upstairs on the second floor. Now please join me in warmly welcoming this year's honored Meredith E. Drench lecturer, Dr. Alyson J. McGregor.
Thank you so much. That was so lovely. Appreciate it. Great. Wow. Thank you so much. It really is such an honor to be here, especially as a graduate of Boston University School of Medicine. When I was here, it was separated. It was the university hospital, the city hospital, and then the university section. So that's going way back. And I feel so fortunate to have been educated by this institution. You know, medical institutions are responsible for educating future healthcare providers. They're responsible for promoting state-of-the-art research and technology. But they're also charged with leading innovation and instilling within us the skills to be able to advance the practice of medicine. How many of you here are in clinical care? Either healthcare providers or... How many of you are primarily researchers? And how many of you are just here to hopefully be entertained for an hour? Good, because we need all of you. There is a movement in scientific research that is challenging the delivery of medical care. The fundamental characteristics of sex and gender are increasingly becoming important determinants in health research, in congressional and federal policy, and public urgency. How do we begin to incorporate these fundamental characteristics into our future? I like to start at the beginning, just to make sure we're all on the same page, and then we'll build from here, okay? So clearly we look at this question and we know men and women are not the same, right? But let's think of it in a different way. What about two people of the same sex, right? If you compare the genome of two men or two women. So if you're a man and you're sitting there and you're sitting next to another man and you're thinking, well, clearly we're not the same, right? We don't look alike, we don't act alike. But your genome is 99.9% identical to that of the person of the same sex. That means all of those phenotypic differences, those environmental differences, the hereditary differences are all encompassed into 0.1%. So when you compare the genome of someone of the opposite sex, it's actually 15 times more different. What's making up such a large difference? There's an entirely separate pair of chromosomes, the 23rd pair. These chromosomes are not just in the ovaries and the testes. They're in every cell in the body. They're in your heart cells, your lung cells, your liver cells. And what are they doing? Are they just lying there dormant like they did their job? Right? They assigned you your gonads. Would nature waste that much space? The concept of sex chromosomes deciding what sex organs you got, and those sex organs would be responsible for secreting and regulating sex hormones, and then those sex hormones would be the differences that we see between men and women. This is what we were taught. But we also thought the earth was flat at one point too, and clearly we didn't get that right. The longer you're involved in medicine and science, actually the more humbling it is. The more you realize that it evolves and you have to evolve with it. So that concept really became what we built our medical science upon and what we even created legislation around. We now know there are important differences even before differentiation of the gonads at that cellular level of the embryo. If I were to ask everybody here to get a pen and paper and write down what you think those chromosomes are doing in those cells, you could do it. You already know. You just don't know you know. Because the truth is men and women are not the same in face of disease, and we can see this every day. Sex differences in health are way more common than we ever imagined. 78% of all autoimmune diseases occur in women. Men are 30 times more likely to die of sudden cardiac death during exercise than women. Heart failure mechanisms are now known to be different between men and women. 80% of the over 200,000 hip fractures that occur in the United States are in women. On and on and on. And these differences cannot be explained away by just differences in sex organs or even sex hormones. Even when a disease occurs in both men or women, someone seems to have a greater incidence or a greater severity than the other. And it has to do with sex. XX versus XY, or some combination of the two that we see with intersex, is a major determinant of health and disease. those autoimmune diseases occurring in women are occurring at the chromosomal gene expression level, as well as gender, how someone presents themselves in society, male, female, transgender female, or some combination of all of that, is a major determinant of health and healthcare delivery. For instance, we are losing men by the truckloads every year because of internal and societal pressures to drive fast cars, get up on those ladders, do those risky construction jobs. More men die from trauma-related illness than women, no matter what region of the world you're looking at. Now, I used to think it was really important to determine, is this a sex effect or is this a gender effect? And I think there's still value in that, especially when you consider a transgendered person. If you have a transgendered woman come into your hospital, your office, your emergency department, complaining of chest pain, you have to think that her myocardium, her heart cells, her coronary arteries have XY in them. So she's more likely to develop occlusive disease earlier in life. Yet because she declares herself a female, she's probably also more likely to delay seeking care by 2 to 3 hours, or more likely to want to discuss disposition and treatment issues with family and loved ones. So it's understanding this and personalizing. But the farther this does evolve, the more we realize we can't tease those two apart. It's this concept of epigenetics. Male and female sex cells can have differently expressed imprinted genes beyond that for which we would expect to see with just merely as a response to testosterone or estrogen. A common example of this is African American males. Why is it they have such difficult to treat hypertension? And the theory is that over time and over generations, that constant surveillance and that psychological stress has changed their genes. It's this concept of biology affecting social construct and social construct affecting biology. Your relationship to your environment can increase or decrease gene expression. But why is it our diagnostic cures, treatment modalities have not been taking any of this into account? It really does date back to human subject research. And when I think about what happened with the male-female issue in sex and gender, a good example to look at is thalidomide. Thalidomide came out in the 1960s, and it was found to be an effective sedative. And this was the 1960s. Sedatives were cool. So they gave them to lots of people, including women of childbearing age. What happens when you give things to women of childbearing age? They have babies. And so there were lots of malformed teratogenic effects. And so that prompted the National Research Act that said, whoa, that is unacceptable. And so they created the IRB that we utilize today and we rely upon. But they also created a moratorium on conducting any research on childbearing age women. And you know what? Everybody at this time thought this was a good idea. This was not a gender bias against women. This was generally considered scientific responsibility. And so what happened was people thought this is pretty good because men are a homogeneous subject to study. You could get precise results. You don't have to worry about the constantly fluctuating hormone levels. In order to control for that, you have to power the study to make sure that that variability is not affecting your outcome. So there's this concept that, if we just study men, we could find out what's really going on. And researchers will still say that today. And it's very important to study men, but you're finding out what's really going on in men. There was this misconception that outcomes in men would be adequate proxies for outcomes in women. And so women were left off the research pipeline. Research was performed on men, and even male animals. And I like these two slides because they really do show a visual. This is what happened. If we're studying everything in men, stroke, cancer, heart disease, what's the one thing we can't study in men? Breast cancer, having babies, maybe menopause, menstruation. And so what happened is it trapped all of the efforts into providing medical care for women into only those issues. If you were to walk out onto the street right now, in fact, someone here just gave me the answer. If you were to walk out and just ask women, what's your greatest health concern? What do you think they're going to say? Breast cancer, right? Heart disease is the #1 killer for both men and women. Right? So all in all, by trying to protect women, we actually did them a major disservice. So we learned a lot from Ambien. Ambien is the most widely prescribed drug to treat insomnia. In fact, it's one of the most widely used medications overall in the United States. What it did was demonstrate exactly what can happen when we don't fully understand the importance of sex differences research. Ambien was released onto the market in 1992, but it wasn't until recently that an important relationship was discovered. The higher the blood level of Ambien in your system the following morning, the less alert you are. Seems like an obvious relationship, right? But science is not about making assumptions. What happened is the drug company wanted to make a new formulation of the drug called Intermezzo for middle of the night awakening, because we need a drug for every possible indication we can come up with. And they discovered something remarkable. The amount of time it takes that you should have before you take this drug, the bottle will say, if you take this, make sure you get at least 4 hours of sleep. They stuck people in driving simulation studies. These are the same type of studies we use to determine blood alcohol levels in driving. And the women did horrible. Now, inevitably, someone will tell me, but women are bad drivers. I'm like, it wasn't because you think women are bad drivers. They actually tested the serum concentration, and the women had 2 times the concentration. They gave them both the same dose. So they were able to make that connection with higher serum concentrations and impaired driving. The Institute of Medicine has said 1 out of every 5 serious injuries from a driving accident is due to driver sleepiness. When do people take medications to help them fall asleep? When they want to be really alert the following day, right? I've got a full day of work. I want to try to make it to that gender talk, right? It's a long day. Without ever realizing that the simple act of getting in the car the following morning put thousands of women at risk. And fortunately, we now know the likely mechanism is sexually dimorphic expression of alcohol and aldehyde dehydrogenase that prevents men from absorbing as much of the drug as women. Unfortunately, the recommendation is now that women take half the dose as men, but that's after a 20-year prescribing history and over 700 Ambien-induced impaired driving reports to bring about that change. This is what our trauma rooms look like after a motor vehicle accident with serious injuries. And I apologize if this is not something you're used to seeing in clinical care, but I unfortunately am. You need to know we're not talking about a neck sprain or a backache. We're talking about serious injuries that's life or death. That sex-specific labeling revision represents an evidence-based approach of capturing data for dose individualization and risk management. Think about it. How many Ambiens are out there? From the moment a pill is consumed to everything about how the body handles that drug, the pharmacokinetics, and what the drug does to the body, the pharmacodynamics, has been shown to be different in men and women. Many people feel like differences are mostly due to body weight issues, right? Men and women usually have different body weights, and drug dosing is based on a 70-kilogram male. And that is very important and can have significant impact. However, even when you control for weight, there are important differences in the bioavailability, the distribution, the elimination, metabolism. For instance, women have a lower concentration of gastric enzymes than men, which can lead to greater peak concentrations. So if you weight-based dose alcohol and you give it to both men and women, the woman is going to have a higher peak concentration, greater cognitive impairment, greater liver toxicity. Women have slower gastric emptying times, decreased intestinal transit times. They have a different gastric pH, which really affects metabolism of drugs. We don't really consider any of this. Let's consider the QT interval. So for those of you involved in clinical care, you realize as the QT interval prolongs, it can lead to a fatal arrhythmia called torsades de pointe. For those of you not in clinical medicine, think of it this way. Every time the heart beats, it needs to recover so it can beat again. The QT interval is a measure of the recovery time. This is very precise, okay, and it's timed specifically. How many of you here knew that women have a longer QT interval on average than men? This is a sex-based difference that occurs at puberty. During puberty, boys have a surge in testosterone that upregulates potassium channels in the myocardium all around the heart. Those potassium channels open up. All of a sudden, you get a flood of all these processes, the action potentials. You get a shorter QT interval, right? A quicker repolarization, a quicker recovery time. This is a protective effect for boys that persists throughout their lifetime. And you can see as testosterone levels start to wane, as men get older, you can see the QT interval begin to prolong again. Subsequently, having the chromosomal complement of XX is an independent risk factor for torsades, which really matters when women take medications. What medications increase the QT interval? Anybody know any? The reality is it's easier to ask the reverse question. So many medications increase the QT interval. Okay, so let's consider a patient scenario. You have a patient, they have chronic pain, they have debilitating physical disabilities with pain. So they take methadone, and at night they take trazodone to help them sleep. And they just did a bunch of cocaine, unfortunately, and now they're going crazy. And so EMS brings them into my emergency department, and so we say, okay, we're going to give them something to relax them. We're going to give them Haldol, which works, and we give them Benadryl just to make sure they don't have a bad reaction to the Haldol. And then as you're getting ready to discharge them, you're reviewing their blood work and their urine, and you're like, oh, they have a little bit of a urinary tract infection. Let's just give them some Cipro antibiotic. You're thinking, I see them all the time. I'll see them next week. And when they're found down next week, it's going to be considered a drug overdose, which is partly true, right? Especially if that patient was a female. It's a stacking effect. Women take more prescription medications on average than men, and doctors are unknowingly prescribing them without fully realizing this drug-related health risk. So it's not just about knowing baseline physiologic differences and then knowing how maybe endogenous hormones, it's then just how does your intervention affect that? What has been the consequence of not really realizing how important these differences are? Because we feel like we're practicing evidence-based medicine. We're looking it up. We're going to the bedside. We're talking about it on rounds. We're giving lectures on it. But what is our evidence based upon when 76% of cell-based researchers don't even know the sex of the cell they're studying? Never mind how it affects their analysis or their conclusion. When 80% of animal-based research is on male animals. Human clinical trials, this is a moving target. Women make up over half the population, and they're the healthcare deciders for their entire family. So how generalizable is this research to the general public, to you? The FDA approves drugs for sale in the United States based upon demonstration of clinical benefit outweighing any potential health risks. And they do this by reviewing data submitted to them, data based on, say, several thousand subjects. Now, historically, those subjects have been young, male, healthy volunteers. Dr. Francis Collins, the director of the NIH, gave a compelling TED Talk recently where he discussed the systems of drug discovery. And he spoke to the fact that it takes upwards of 14 years and $1 billion to get one drug approval. And now that drug is available to be given to hundreds of thousands of not so convenient sample of subjects that include women. And that's when we start to see adverse drug reactions that we did not expect to see beforehand. The famous government accountability study reviewed a year's worth of drugs that were withdrawn after being approved and after being in the market. So I said, well, what are we talking about here? What types of drugs and what's going on? And what's interesting is half of them were due to differences in gender prescribing trends. Appetite suppressants, gastrointestinal disorder drugs are more likely to be prescribed to women. So if you're studying in men, you're going to see things that you didn't expect to see. The other half were equally prescribed to both men and women, but the woman had the adverse drug reaction. So what adverse drug reaction are we talking about here? We're talking about torsades. 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 Now, I just mentioned that we already have this understanding that women have this increased drug-related health risk. Yet we're discovering this after a drug is out in the market. We're not talking about nausea. We're talking about walking down the street and dropping dead, whether you're 30 years old or 70 years old. Here's something else to think about. 80% of the prescriptions filled in the United States are for the generic equivalent, making generic formulation processes perhaps more important than we thought. In order for a drug to be considered equal to a brand name, it has to undergo what's called a bioequivalence study. So let's take a closer look at what a bioequivalence study really is. It's what's called a crossover study design. It's where they give the generic drug to a subject or a group of subjects and obtain measurements for a couple weeks. And then they wait a couple weeks and let it wash out. And then they give the brand name to the same subject or group of subjects and obtain the same measurements. It's pretty simple design. And then they compare the two. Now, these studies are performed almost exclusively in men. And the argument in favor of that is that because they're giving it to the same person, they essentially act as their own control, so sex doesn't matter. It's this hypothetical principle of if they were to expect any variability between the brand name and the generic drug, in men it would probably be just as variable in women, right? This is what they're measuring. They're measuring the peak concentration and the overall concentration over time, shown here in red. And there's a 20% fudge factor. You can be a little more bioequivalent and be approved and go on the market, or you can be a little less bioequivalent and be approved, right? So there's, as long as you're within this particular acceptable frame. So let's just take a closer look to see if that variability hypothetical principle is actually true. The Center for Drug Evaluation and Research tried to look at this, and it turns out it's harder than they thought. They reviewed 18 years worth of data, and in 18 years, just upwards of 23 studies were submitted that had women to be able to compare. For your comparison, think about it this way. There are at least hundreds of drugs that are generic drugs that are approved every couple months. Right? So 18 years worth of data, 23 is pretty low, right? So what they did was, and I'm just going to show you two examples. This is just about pulling the curtain back, right? I just want you to kind of say, I didn't realize this mattered. So it's this concept of variability. And in the animal studies, this has been one of the reasons why they liked, researchers prefer to study male animals, because they feel as though female animals are too variable. But there was a very robust meta-analysis that actually disproved that and reviewed over 40 strains of mice and found that female mice were not more variable. In humans, however, sometimes women are more variable, sometimes they're not. Sometimes men are more variable. You have to look each and every time. So if we're looking at percent coefficient of variability, this is the variability in that red, the area under the curve. And if you look at a very common drug, alprazolam, this is a benzodiazepine. This drug is for anxiety, for muscle relaxation. It's a very important class of drugs. And they found that it's not very variable. This was not a very variable number in men. But it jumped six-fold when it was given to women. What this means is that for this drug company to have this be approved, they would have to include many more women in the study to power it to show that it's not too variable for it to be given to just anyone. So then they looked at what's the bioequivalence average, like the main calculation that they make. How does that differ between men and women? And a very common antibiotic that we use found that it was 42% greater bioequivalent in men. What does this mean? This means that if this drug was tested in men, it would be approved, and women were 42% lower under the curve. It would never be approved in women. It would be completely ineffective. What all of this is demonstrating is that sex and gender have major implications on the interpretation and the generalizability of this type of research design. That's not all. I know I want it to be too, but at times an adverse drug reaction can be due to something other than the active ingredient, like the inactive ingredient. A common inactive ingredient is polyethylene glycol. Polyethylene glycol has been shown to increase that bioavailability of the active ingredient in a dose-dependent manner, which is pretty cool. We love polyethylene glycol, actually. Doctors like to take advantage of its hyperosmotic, low-absorptive properties. In fact, many of you probably really like it too, because it's also known as Miralax, which is a very common laxative that we prescribe and perhaps utilize, right? So the interesting thing is, this same research study showed that when polyethylene glycol is mixed with ranitidine, this is Zantac, and then you give this combination to men, it increased the bioavailability by 63%. That's amazing. This company can then even use less of the active ingredient, which is more expensive to make than polyethylene glycol, and then you'd still have great effect, therapeutic window in men. But when you gave this same combination to women, it decreased the bioavailability by 24%. This would render this drug completely inactive. So then I think, okay, well, how many drugs contain polyethylene glycol? And here's a list of just a few of them that I personally rely upon to treat my patients. So then the question becomes, have we tested all drugs that contain polyethylene glycol in both sexes? And if the answer is no, or even I don't know, what are our female patients left to believe? That the side effects that they're experiencing, that the fact that they just don't feel right after their insurance company or their pharmacist or their doctor or their hospital has this automatic switch to generics. Generics play such an important role. They make medicine affordable. So this is not against generics. This is about the processes by which we approve and we utilize and we rely upon them. Oftentimes, the prescribers or clinically relevant researchers are blinded to the way that evidence was obtained when we're practicing medicine. Do we believe that men and women are different enough to design our studies to detect those differences? So I always look at the emergency medicine literature a lot. And I just pulled this out because it's going to show you this really important point. So this study found that why do women wake up faster from men from propofol anesthesia? This is a very common drug that we use during procedures, and the operating room uses it. And they found that the emergence time, the wake-up time for women is shorter, likely due to the fact that women have higher body fat percentages. So it can lead to lower concentrations of lipophilic drugs like propofol. Now, many times adverse drug reactions are dose-related, so here's an opportunity to give men a lower dose to achieve the same serum concentrations for effective procedural and post-intubation sedation. So then, this just came out a couple months ago, and here's a study that looked at that drug in combination in an ED-based population, and what was remarkable is they achieved almost 50% enrollment of men and women. But what they failed to do was to go to that next step and to find out any sex-based properties or dosing strategies. Because what they did was they pooled the results, and then they made their conclusion generalizable to anyone. Now, the NIH Revitalization Act did say start including women in clinical trials. But what we need to know is that it's gone beyond that. Last year, the NIH said anyone asking for funding needs to make sure that they include sex as a biological variable in the analysis, in the interpretation of the data, in the validation of the results, and the generalizability of the outcome. And if you don't do that, you have to actually ask, permission. You have to explain why not. And it's not just about funding. When you pull together the results, you can actually be ruining it for both men and women. Let me show you what I mean. This researcher wanted to look at the relationship of women who are pregnant and smoke. What's the likelihood that their offspring are going to develop psychiatric disorders during adolescence? Schizophrenia, bipolar, anxiety, depression. And they found this remarkable association between nicotine and a myelin basic protein. And that relationship was dependent on the fetal sex. When the fetus was a female, it decreased the expression of that myelin basic protein, which actually led to an increase in developing those psychiatric disorders. When the fetal sex was a male, it increased the expression of that myelin basic protein, which actually was a protective effect for men, for boys. What would happen if this researcher pooled the results? Say that again? Cancel each other out? Yes, exactly. They cancel each other out. That's exactly the point. So if you think about this, these are our building blocks, right? This is why even animal-based studies and cell-based studies and even before you get to a clinical application, how much of the evidence that we rely upon are based on pooled or potentially hidden or even inaccurate data?
Excuse me, I just asked,
yes.
Why is it men? Why is it men that get all the studies and women?
It started way back when women were considered a protected subject. So just at the time when a lot of evidence-based medicine was really starting to come up into the pipeline, that was just at the critical point where women became a protected subject to make sure that they don't have any teratogenic effects during pregnancy. So we got used to studying men. So if we think about this in a very clinical-based area, right? How much, what has that lack of understanding done to our framework of practicing clinical medicine, real medicine, right? So cardiovascular disease is the #1 killer for both men and women. But why is it that women are more likely to die after having a heart attack? Women have higher in-hospital mortality than men. So maybe it has to do with sex-based physiologic factors. We are very comfortable with a large coronary artery developing some plaque, that plaque getting larger, it rupturing, you get a platelet-rich thrombus, it causes a downstream obstruction, causes a local area of the heart muscle to die, all of a sudden these levels of troponin, a nice biomarker are measurable. This is focal obstructive disease. We're good with this. What we're not so good is this disease of the smaller arteries that we're realizing probably has more consequence right now. It's this disease where they vasoconstrict. They have endothelial dysfunction, altered vasodilatation in response to stress, right? If you do an angiogram, there's delayed filling. It's called slow flow phenomenon. What the heck are we going to do with this? This doesn't give you that elevated biomarkers. It gives you more of a heart failure picture. It gives you more of an inflammatory marker scenario. But can have tremendous, this is microvascular disease, tremendous downstream consequences in symptomatology and presentation. Women do have focal obstructive disease, and when they do, it can feel like a ton of bricks on their chest. However, they're more likely than men to develop microvascular disease, and more likely to present with fatigue and nausea, and not feeling right. I saw this poster in an airport by womenshealth.gov, and it stopped me in my tracks. Because I thought, what do we do when these women come into the hospital? If we're lucky enough to even think of coronary artery disease, our current risk stratification tests are designed to test focal obstructive disease. Exercise tolerance testing, stress echoes look for regional wall abnormalities based on an anatomical distribution. Even an angiogram can hide microvascular disease. Maybe another reason is we are continuously looking at male pattern disease and referring it as typical, and then viewing female pattern disease as atypical from that. When it's actually very simple. It's sex-specific pattern diseases. There's sex-specific male pattern diseases, which are typical for men, and then there's sex-specific female pattern disease, which are typical for women. We should be reserving the word atypical for any variations from that. Even simply risk factors. Women have sex-specific risk factors related to pregnancy. Hypertension is a greater risk factor for men. It's viewing these disease states with a gender lens, like if you put on 3D glasses, right? That's what I want. We can probably be able to make some headway into some of these disease states that cause lots of physical and mental disability. Thinking about something as rudimentary and pervasive as pain, this chronic pain issue. Pain is one of the greatest chief complaints in the emergency department. Right? Women do suffer a disproportionate amount of pain and more chronic pain syndromes. Tension headaches, migraines, fibromyalgia, RSD, TMJ. All of these syndromes relate to the way that women develop pain. There's definitely a change that occurs also at puberty, suggesting another relationship between hormones and chromosomes. And women are more likely to be treated with anxiety medications instead of pain medications. Because of gender roles, perhaps, and expression. How is a man supposed to act when he breaks his wrist? How is a woman supposed to act? Then the healthcare provider is just picking up on those clues. We now possess the scientific ability to determine differences in drug metabolism and dose response, and we need to make sure that we do this for every single medication currently in use. I know, it's a lot to ask. Right? As well as those clinical observations, view them as precious clues, naturally occurring disease modifiers. We may, in fact, require 2 distinct lines of research. I can see that. But instead of being intimidated, we should be embracing this divergence of data so we can improve and tailor treatment, so we can add this evidence into our current practice model. As more research that takes sex as a biological variable into account, we're going to have more laboratory value reference ranges that are based on sex and biomarkers. We should be looking at our patient and thinking, what is their biological sex? What is their gender identity? And then using that to base our risk assessment and to decide what tests we need to order and how to interpret those tests, to individualize and personalize so we can be prepared to care for these individuals as well. New state and federal data estimate anywhere upwards of 1.4 million adults now identify as transgender. It's becoming increasingly complex to figure out how do we classify these individuals in research. How many categories do we need? Male, female, do we need transgender male, transgender female, intersex? And then challenging also for clinical care, but we need to get better at it. At Brown, we have a division dedicated to adding to the literature and to education of medical students and residents. We have a 2-year fellowship program. We do a ton of advocacy like this, so we can help a cognitive transformation. The American Medical Association, as a specialty as a whole, just passed a resolution. Council of Science and Public Health, they did two amazing things. One, they changed the definition of women's health. It no longer means reproductive issues. It means everything what makes a woman may be different in health than man. Men's health, everything that makes men different in health from a woman. The vocabulary is changing. Prostate cancer is a sex-specific issue for men. Ovarian cancer is a sex-specific issue. Okay? Men and women's health is different. They also asked all of their members to start incorporating this impact right now in clinical care. Not later when we get more research, not we'll just, do it, maybe some education, right now. And I think this is the key. In conclusion, the Institute of Medicine has said repeatedly that being a man or a woman significantly alters the course of a disease, and that this fact must be included into our diagnosis and our therapies. We have this opportunity, and I would argue an obligation, to figure out how our patients' sex and gender affects the clinical care that we provide. The sooner we begin to incorporate this into the way that we conduct research, in the way that we practice medicine, and the way that we educate, the sooner we can make a difference. We are making great progress, but our future is about getting it right. Thank you. There's a lot more stuff out there, really. So please ask questions. It'll give me an opportunity to share some more things that are going on. Oh, and we want to make sure that you use the microphone because it's being recorded. Thank you.
Hello. Thank you very much for the talks. It's wonderful. I had a question about the slide you showed with respect to the variability between men and women with the use of the generic drugs versus the non-generics. Mm-hmm. And since the study was so heavily weighted with more male studies, how did they correct for that type of statistical analysis? Because you could see more, because you're sampling such a smaller population size with the woman.
Those were submitted, those were not approved. So that was a collection of submitted. I don't know if eventually that drug made it to the market of those particular things. So out of that 18-year search, it was very difficult to find any submitted studies that even had women. Mm-hmm. So that's what you mean, right?
Well, I mean, given that fact, how could they statistically compare the two groups just because the sample sizes are so enormously different? Like, that's a challenging statistical question. I'm wondering how they found those results, or if you know that.
Oh, I have the reference, though. I can show you. I'm not sure about the answer to that question. I know what we need to, the ideal is to, the gold standard is probably going to be powering a study. However, I know that they're looking at this at the FDA and trying to figure out that's not always realistic, because we don't want to make studies cost so much and to take so much time that they're not available important drugs to be used. So I know they're looking at maybe mirroring the prevalence of the population. So something like that might be an option. There's also the SAGR guidelines, which I think are really wonderful, that help researchers, peer reviewers, and editors learn how to design their research from start to finish, from the hypothesis. They have checklists for analysis, how to at least make it at least enough to be able to make any sex-based differences and properties.
All right, thank you very much.
Of course. I'll let the microphone be the...
Hi, I think I'm curious about where do we start? Because there's so many people involved in this, so we need to get providers on board, we need to get the government and policy on board, we need to get insurers on board and pharma on board. Where do we start? Who do we target first? Yeah. Yes,
that's a great question with a long answer, and I was talking to someone else about that also. divided up into 3 areas. So we need to get research, education, and then clinical practice on board. And all of these 3 need to happen simultaneously to make a difference. So a lot of the organizations I'm involved in, we're doing things at each level. So making sure that research is conducted using things like the Sager guidelines. NIH has a online a module to learn how to incorporate sex and gender into your research studies. Canada is a very much ahead of us in that too. Their CIHR has modules also looking at how to incorporate sex and gender in primary and secondary data sets. So there's some great stuff to start doing there now. I think clinical practice, it requires a lot of cognitive integration. So it's that mental switch. So there are steps that we are teaching to take. There's a validated PubMed search tool, and I brought some materials here. Where you can actually look at this, you're seeing a patient and you're like, I wonder what the differences are between hypertensive emergency between men and women. You can do a dedicated search to get just the literature based on that. And then use that in your clinical care. One of the things we do is put together a textbook, because a lot of this information is diffuse, because you have a couple champions in each area that that are interested in found a sex difference. So we collated that for this textbook for very clinically relevant, high public health significant issues, stroke, heart disease, that sort of thing. And then education, we are working with the medical student institutions. We had a summit in 2015 with over 100 representatives from the medical schools across the country, and had international representatives to try to figure out what are some barriers for integration. And then we're hosting another one next April, not this month, but next year, to do that with interprofessional organizations, so dentistry, nursing, physical therapy. So that's really exciting because it can't just be about the one person, it's everybody. So there's lots of things underway, and thank you for asking that question. I can repeat it.
Yeah, so on a very personal level, when I go look at my medicine chest tonight,
Yeah.
I don't have a lot of confidence.
I know, I'm sorry. So the question is, how much confidence can we have in our medicine that we are taking right now? And, I think you play a very key role here too. It's not just about the people who are involved in education and research. I think in general, as a patient, because many of us are, discussing this with your doctors. So the FDA has an online, they just put lots of resources and money into this. It's called Drug Trial Snapshots. And any newly approved drugs are on there. And you can see how many men and women were enrolled. Were there any differences in side effects or benefits? And then they ask you, you're going to be staring at the computer and being, what do I do with this information? Now talk to your doctor about it. Your doctor may not be on the in of what sex and gender means. But by you bringing that conversation up and that question to them, it's going to have them start to look it up. So, I think the public can have a tremendous amount of power and change. And so I have these conversations with your physicians. We have more questions than answers right now, unfortunately. But let's start asking the questions and just start thinking about it in the right way.
Is it also the case that trials don't include children?
Not so much anymore, actually. They, and I talk about that sometimes because we have pediatrics, we have adult, and we have geriatrics. And I've been thinking that more and more lately, that's really about hormones and cellular aging. But, because there's definitely differences from puberty on. But there is research on children for pediatrics. They've just created a very robust informed consent process for parents, and there's a lots of oversight to make that happen. And I think that women want to be also included in studies, and I think we need to do studies on pregnant women. we really don't know a lot about, we don't know anything about medications in pregnant women besides the bad ones and just take Tylenol because we don't know anything else. And I think that pregnant women may want to be a part of this. It comes down to really good informed consent, having really good primary data, either in animals, pregnant animals or whatever, having something so that there's enough information there they can make that decision. I think right.
So you had alluded to this briefly, but it was obvious when you show the differences between the sexes that a lot of the ailments that are more common in women, like fibromyalgia and psychological conditions, there's an inherent bias in medicine where it's easy to pin women as crazy or all in their head. Do you have any suggestions, recommendations on how to address those things as a medical provider to other medical providers when you see that in a hospital setting?
And I do because, so I teach residents too, and so I will often hear a resident say, that patient in room 4, it's a female, and they're complaining of abdominal pain, but I think it's just anxiety. And so I do teach the fact that there's great, interesting stuff out there on pain. It really, it's fascinating. But there is the detection of pain. So a body detects that I'm in pain. Okay, I just cut my arm. I'm detecting that. And then there's an emotional response to that. So it feels a certain way, and it may feel the same stimulus between men and women. However, there's an emotional response to the fact that you're cut. And maybe you're thinking that, I've got to go do this and that, and then go pick up this one. Women more likely multitask. So then there's going to be an emotional response to the pain. It may be anxiety as an emotional response, and maybe men have less anxiety about having a cut. So the healthcare provider is picking up on that emotional response and just assuming it's based in anxiety, when actually it's based in the fact that they cut their arm. So yeah, they may be anxious as well, but let's treat the pain, and then maybe the anxiety will go away. It's a secondary thing. So it's those sort of on-the-job training nuggets that I do. And then you could advocate for yourself that way, as a patient, if you just have that conversation. I know I look very anxious right now. I have a lot of things on my mind. However, this hurts. I think she's been waiting.
You mentioned like microvascular disease being common in women, but you said that certain tests can't detect it. What kind of tests do detect it?
There are some tests. There's going in that artery and squirting acetylcholine to seeing if it. There's capacitance testing. Nothing that is from an emergency point of view. And a lot of this is research-oriented testing. So there's this Women's Health Ischemia Institute. I'm saying it probably wrong, but Dr. Noel Berry-Mears in Cedars-Sinai is leading that, and she is trying to make it more, add to the research on this and literature, try to figure out how can we best detect this. So I think that definitely needs to come, and then us to figure out what kind of consequence does microvascular disease have. Can we decrease its debilitating effects by just risk factor modification? We don't even know that connects. I think more and more light is being shined on it, but we are far from our typical come in with chest pain, EKG, lab work, admit to the chest pain unit, you get your chest test, you go home. Well, we have this very routine process that we do, and microvascular disease falls out of that. So it's the chronic, it's the women mostly. Men have microvascular disease too. And it's the chronic chest painers that probably have something like that's going on. Last question.
Hi. You had mentioned that that women are on more prescriptions than men are, and I would imagine that a lot of that is birth control. And so would if we're starting to look at these studies in terms of men separate from women, and many women are taking birth control as a hormonal control as well as to prevent unplanned pregnancy, would it be also important to separate the women who have hormonal control from women who aren't having that hormonal control?
That's a great question, and what's interesting about okay, that's okay. So many things just flooded in my mind with that, because one of the problems is how many groups do we really need? You know what I mean? Like, to make sure that we get the right information, you know? And so I think most of the time birth control pills, women don't even think to tell us that they're on it. You know, are you on any medicines? No. Do you have any medical problems? No. They forget that it even matters. And you know what? To lots of doctors, it probably doesn't. So I can see why that has. Sometimes it's been suggested that if you are going to time a study, one theory is to time it in month increments. That way, if you have women in the study, which I hope you do, and I hope that you're analyzing it based on sex, the cyclic cycle, most women have their full cycle in about a month, right? Give or take a few. So if you have a trial, make it be the length of the month. That way all women will at least, when you pull together all the women, you'll at least, they'll all be at least average the same in follicular stage and luteal stage. So at least you'll have some sort of consistency there. You're not stopping it in your follicular phase and then having that alter drugs, because menstrual cycle does alter medications as well. So the fact that you're taking exogenous hormones is definitely critical to your health and to the fact if you were in a study. And I think as more transgender persons take hormone therapy, it's going to be very important to take that into account. One example is looking at laboratory value reference ranges. So if you have someone come in and they're transgender, what laboratory value reference range do you use, right? So the thought is that if they're not on hormones, you use their biological sex as the reference range. And then when you're thinking of their gender risk, you're using their gender identity. But if they're taking hormone replacement, they're probably altering their chromosomes, their genes, at least enough to fit into the transition gender. So long answer to, it really does matter. And so make sure that you if you ever join a study or you design a study or you have your doctor know if you're on any. It's a good question.
So, thank you all for coming.
Thank you for having me. That was fun, yeah.
Yeah.